Long before we had all these high-tech scans, doctors had this incredible way of reading the body, kind of like a map. And maybe the most detailed part of that whole map is the cardiovascular exam. It's this amazing, real-time window into your heart's health, and all it takes is a pair of hands and a stethoscope.
So it really makes you wonder, right? How much can a doctor actually tell just by, looking, feeling, and listening? Well, it turns out a whole lot. So let's dive right in and see how just a few simple maneuvers can uncover everything from your heart's rhythm all the way to the pressure inside its chambers.
Okay, so first things first. Before a doctor can even begin to interpret what they're hearing, they've got to know exactly where they are. It's kind of like being a navigator for the human body. It's all about creating a reliable map of the chest.
So how do they stay so consistent? Well, clinicians basically create a coordinate system right on your chest. They use the landmarks you can easily feel, like your sternum and your ribs, and then they add a few imaginary lines to create a grid. The whole point of this is to make sure that any finding can be pinpointed to the exact same spot by any doctor at any time. It's super important for consistency.
And you know what? The absolute key to this entire map is one single crucial landmark, the sternal angle. It's this subtle little bump where the top of the sternum meets the main body, and, this is the important part, it lines up perfectly with the second rib. This gives doctors a rock-solid starting point. From there, they can just count down to find any other rib or space. It's the fixed reference point for absolutely everything that comes next.
All right, with our map of the chest laid out, let's move on to reading the pulse. And believe me, this is about so much more than just counting beats per minute. The pulse actually tells a really detailed story about the heart's rhythm and its strength. So, doctors will check for pulses at a few key spots on the body. Now, for someone who's young and healthy, just checking the radial pulse at the wrist is probably enough. But, and this is important, for older patients or anyone with certain risk factors, checking the pulses down in the feet is absolutely crucial. It's a key way to spot something called peripheral vascular disease.
So a huge part of this is just assessing the rhythm. A normal pulse, it's like a metronome, just steady, predictable tick-tock. But sometimes, it feels completely random. There's no pattern at all. That's actually called an irregularly irregular rhythm, and it is a classic textbook sign of a pretty common condition called atrial fibrillation.
And it's not just the rhythm, it's the strength of the pulse, too. That's also incredibly telling. What you're actually feeling is the pulse pressure. That's the difference between the peak pressure when the heart squeezes and the lowest pressure when it relaxes. So if a pulse feels weak, that can be a big clue that something's messing with blood flow. It could be something like atherosclerosis, a hardening of the arteries, or maybe low cardiac output, which just means the heart isn't pumping as hard as it should be.
And this brings up a really great point about the physical exam in general. Clear communication is everything. You see, instead of using some vague 0 to 4 scale where, let's be honest, nobody quite agrees on what each number means, it's just so much better to use simple, descriptive words. Is the pulse normal? Is it diminished? Or is it maybe bounding, which means stronger than usual? Using plain language avoids any confusion.
Okay, next up, we're moving to what I think is one of the most elegant parts of the entire exam. It's checking something called the jugular venous pressure, or JVP for short. And what's so cool about this is that it's a completely non-invasive way to get a look at the pressure right inside the heart.
So what is the JVP? Well, it's basically a stand-in, or a surrogate, for the pressure in the heart's right atrium. Just by looking at how high the blood pulsates up the jugular vein in your neck, a good clinician can get a surprisingly accurate estimate of what's called the central venous pressure.
Probably the best way to think about this is to picture the jugular vein as a kind of blood-filled manometer, like a fluid ruler. It works because that vein is directly connected to the right atrium, and it's also really flexible. So the height of that little column of blood you see pulsating inside it, that directly reflects the pressure way back in the heart. It's pretty genius, right?
Okay, but here's the tricky part. How do you know you're actually looking at the vein and not the super powerful carotid artery that's right next to it? Well, there are some really key differences a doctor looks for. The jugular vein's pulse is this soft, two-way flutter for every heartbeat. You can't really feel it, and it actually drops a bit when the patient breathes in. The artery, on the other hand, that's just a single, strong thrust that you can feel very, very easily.
And hey, remember what we said about the pulse? About using clear words instead of a confusing scale? Well, that exact same wisdom applies when a doctor is assessing leg swelling, also known as edema. The expert from our source material strongly recommends avoiding that common 4-point scale because, you guessed it, there's no universal agreement on what it means. It's so much better to just describe what you see. Is it mild? Is it moderate? How far up the leg does it go? Clarity is key. All right, now for the part everybody knows, the part you probably picture when you think of a heart exam, listening with the stethoscope. We're going to decode that famous lub-dub and, more importantly, all the little subtle sounds that can happen in between. So, at its most basic level, the heartbeat is made of two main sounds. We call them S1 and S2. And when you put them together, they create that classic, familiar lub-dub rhythm of a healthy, happy heart.
But what's actually making that noise? Well, S1, the lub, is the sound of two of the heart's valves slamming shut as the heart begins to contract, or squeeze. Then S2, the dub, is the sound of two different valves closing as the heart relaxes and fills back up with blood. So just think, lub-dub, squeeze, relax. That's the cycle.
But sometimes a doctor hears extra sounds, and the most common one is called a murmur. A murmur is really just a whooshing noise, and it's caused by turbulent, kind of chaotic blood flow. A lot of the time, this is a signal that one of the heart valves isn't opening or closing quite the way it's supposed to.
And here's where things get really interesting. Murmurs have different characteristics that give clues about what's causing them. For instance, they have a shape. A sound that gets louder and then gets quieter, what we call a crescendo, decrescendo, is a classic sign of a condition called aortic stenosis, which is a narrowing of the aortic valve. See? The shape of the sound literally tells the story.
So, when you step back and put all of these seemingly simple observations together, you've got the map of the chest, the story from the pulse, that pressure reading from the neck, and all the sounds from the stethoscope, you start to get this incredibly detailed picture of a person's cardiac health.
I mean, think about it. This one exam gives you the heart's rate and its rhythm. It gives you clues about the health of the arteries, from the neck all the way down to the feet. And it provides direct insight into the pressures inside the heart and how well all its valves, its basic plumbing, are working. Which, of course, leads to the big question, right? In our modern age of high-tech echocardiograms and CT scans, is all of this just obsolete? Is it just a relic of a bygone era?
The answer is a resounding no. Absolutely not. The physical exam isn't just some old tradition we hang on to. It is a powerful, essential diagnostic tool. It gives you an immediate, dynamic, and just incredibly rich window into how your body is functioning. And it's all happening in real time, right there at the bedside. It connects the doctor to their patient in the most fundamental way there is.